Hi, everyone. Welcome to CMDA Journal Club. I believe we are on Thursday, April 3rd. We want to remind you of our annual conference on Friday, April 25th. And I have on our website, go to cmda.us, click on the lead page to register for the conference. We're really excited, as we are every year. We have a great lineup of speakers. And actually, our speaker today will be presenting, Dr. Fixen will be presenting in a panel on marijuana at our conference. We're also excited every year for our Cam Ducky Derby, run by Dr. Greg Gom, to show us how much we should have learned throughout the year through our education programs each month, the first Tuesday of the month for the CMDA meeting and the first Thursday of the month for our journal club, which is where we are today.
I can point out that there is a change to this agenda. We have to update our website, but Dr. Lambitz can't make it to the conference. So we've rearranged the schedule so the other speakers will still be on there and everyone can still get the same amount of CME credit for the conference. But that's the one change that I'll just make verbally right now.
Is Dr. Fixen on?
I don't see her on yet. She just did say she was coming a few minutes ago. Yeah.
And for those that are on, we are always looking for topics for our monthly meeting. So please, we try to figure out what we're interested in, what we think you might be interested in, but please reach out to us. I have several facilities that are struggling with smoking policies. So that may be something, but we would love to hear from you, our members, what you're seeing in the community, what you need help with, what you'd like more education, more information on from the community.
I'll check with Dr. Fixen to make sure she has the right link and everything.
Okay.
I don't see her on here yet. Yeah.
Chris, in the meantime, I'll just throw out there while we're waiting that
Please.
the first case of measles hit Colorado yesterday, in case people had not heard about that. Unvaccinated child from Pueblo who had been in Mexico in a place where they were having an active outbreak and came back and is positive. So chances are pretty good, as contagious as it is, that we'll see some spread, at least in southern Colorado, and maybe work its way up here.
That's awesome news.
Yeah.
Yeah, one of the sites they went to was Walmart, and I was like, oh, good. So it's
Yeah. It'll spread fast.
It'll spread fast.
Hey, Greg, can I ask you a question?
Yeah.
So as far as testing for that, if we see a case, do you need to go through CDPHE or can we just order PCR swabs, or what's the right protocol?
You can do probably what you want to do. Oh, if you think somebody has it?
Yeah.
Oh, geez. Quarantine, and probably you're not going to know until they have the appropriate rash. Again, there are very few of us old enough to remember what that appropriate rash looks like. But yeah, you're not going to need a swab. I think what's more important for us and what we do is to start asking your staff if they know they got the vaccine. And if they got it prior to 1968, just as a little tidbit, it wasn't as effective as the vaccine we've had from 1968 on. And so if you got the vaccine prior to 1968, or you don't know if you ever got it, you should probably check titers. And if you don't have an appropriate titer, it's a 2-step vaccine, but you should go ahead and get the first step and get things going. It has to be 30 days apart.
Okay, thank you.
Sure. And I see Dr. Fixen is here, so I'll shut myself off now.
Appreciate the update. And I am so sorry, I did send you 2 different links, Dr. Fixen, and the most recent one was the wrong one, so
Oh,
thank you.
no. Yeah, no, I'm glad that it worked out. I was like, well, maybe, we're in Colorado. It could just be like a 5-minute late start. So no, I'm excited to be here today. Let's see, I will share my slides with you all. Should we just like jump in and get started?
Yeah, sure. Do you want to introduce yourself? I think this is a
Yes.
great opportunity for all of us. We're so glad that you're
Yes.
here.
Of course. So my name is Danielle Fixen. I am an associate professor at the University of Colorado Skaggs School of Pharmacy. I have been in Colorado now for about 12 years. I moved out here from North Carolina for my residency, and then I was fortunate enough to stay on after doing 2 years of residency.
It was so much fun.
in
Those people are silent. When that puck is on the ice,
So after doing 2 years of residency, I was able to stay on at the seniors clinic, which is a part of UC Health. And it's a primary care clinic for patients who are 75 years and older. So I'm one of the geriatric clinical specialists in that clinic, where I do like disease state management, and then just help with different consults. And probably one of the areas where is just kind of like a specialty area for me is related to cannabis use in older adults. So we have quite a few patients who are interested in using cannabis, and I've tried to stay up to date on the evidence as it comes out. And from me, kind of my approach is ensuring that I am educating patients on, some of the side effects that could occur, but then also just discussing the limited research that we have available, and ensuring that they understand what could happen and what to expect if they do proceed with using cannabis. So I'm excited to be here today. And I will say I can talk, and I have given presentations on cannabis that last up to 2 hours. So I'm just focusing on one little portion today for cannabis use in older adults, where we'll be focusing on the evidence. But before we get started, I have no conflicts of interest to disclose. And then, as I mentioned, we will be focusing on evidence for cannabis use. I am speaking at the conference later this month as a part of one of the panel discussions. And so if you haven't registered for that conference, this is the plug to register, and please bring any questions that you may have related to cannabis. Hopefully we'll be able to answer a lot of the questions and provide, some patient examples at that conference. But today we'll just focus a little bit more on evidence, give you a background to that, and then we'll have some time for questions as well. So just to get started, I think it's always important, as a pharmacist, thinking about medications that are approved. And the other thing that I just wanted to go over too is you'll see a lot of these names in the studies that I'm going to talk about today. So we have nabilone and then dronabinol. So a lot of the studies use these products when they're evaluating the efficacy of cannabis in different disease states as well as in older adults. There's also an FDA-approved CBD product called Epidiolex. However, it is approved for a very rare form of epilepsy. And so we will not be reviewing that today, but we will talk about, some of the disease states and studies that we have available that have utilized CBD. Before we jump into the studies, I just always like to go over effects of THC and CBD, just so you can understand what patients may experience when they utilize these medications. I know for me as a pharmacist in the seniors clinic, a lot of our patients are going to dispensaries to obtain their cannabis products. A few of them do have medical marijuana cards, but again, a majority of them are getting them from other sources. And so I always think it's important just to know how to counsel them on certain effects that they may experience. So THC, I think the biggest thing to think about with THC is more of the psychoactive effects. So euphoria can cause a little bit of like muscle relaxation. In some patients, it could cause some sedation. And then another one that is just really important when you're thinking about older adults who have certain disease states is tachycardia and hypertension. So there are multiple studies out there that have shown that patients who have, whether it's a history of atrial fibrillation, a history of arrhythmias, where when they utilize THC-based products, that they can actually have increases in their heart rate of anywhere from 40 to 60 beats per minute. So for me, whenever I'm thinking about, a patient who may want to utilize a cannabis product, and I know that they're going to go to a dispensary to get it, one of the things that I look at is if they have a cardiovascular history. And so that would be, a patient population that I would say, hey, I really don't think that a cannabis product with THC is going to be beneficial for you. I worry about some of the risk associated with it. And then we, consider other alternatives for that patient. In terms of CBD or cannabidiol, it really has some pretty, I would say clinically what I've seen is some analgesic properties, some anti-inflammatory properties. So patients who have like osteoarthritis seem to have some benefit with CBD. We also know that it can have some anxiolytic properties, so potentially reducing some of that like anxiety that patients may experience. And then at higher doses, it can cause sedation. I think where I most commonly see CBD being utilized in our patient population is with sleep. And so we will touch on a study that looked at CBD use for patients who were using it for sleep or insomnia. Other side effects that I think are important related to CBD, so what I would call, maybe more of the unwanted side effects are nausea, diarrhea. Again, I mentioned the drowsiness and the sedation, as well as some dry mouth. Actually, both THC and CBD can cause dry mouth. So another thing to just consider when you're thinking about these products is if they're on any other medications that could cause dry mouth. So maybe some of our anticholinergic medications or medications that we use for urinary incontinence, a cannabis product could exacerbate that dry mouth and cause more dry mouth for the patient. So evidence for cannabis use. So this was just a review that had looked at a lot of the studies and the evidence showing, where do we have the most evidence to show benefits, and then what do we have in terms of harms for cannabis use. And so the most benefit that we've seen, and I would say the most robust studies that we have is related to chronic pain and specifically neuropathic pain. So we will discuss that today. The other studies or the other disease states that are listed up here, I'm not going to touch on today just because of time. We will touch on sleep as well, but it wasn't in patients who had cancer. In terms of harms, driving or car crashes, this is really big in our patient population, where we're concerned about reaction time for patients who may utilize cannabis. And so I always discuss what the recommendations are for cannabis use in driving. So Colorado, they have recommendations for patients who utilize THC, and they recommend that if it is an edible formulation of THC, that the patient is using, that they wait at least 8 hours before they're driving. Inhaled is anywhere from 4 to 6 hours. And then we do know that there's an increased risk of psychosis in patients that utilize THC-based products. And so this is something else that we're screening for patients who may have an interest in cannabis use, and then also memory and verbal recall. Okay, so jumping into the evidence that we have, cannabis and chronic pain. So this was a study, a systematic review of 18 randomized controlled trials and 7 observational studies. The mean age is 50 to 65 years. So there were some older adults included, but I do want to point out that there just aren't a ton of studies out there that include like really older adults, especially for chronic pain. The most common pain though was neuropathic pain, and I will say again that's where we see most of the evidence related to cannabis use and where we find it most beneficial is for patients with neuropathic pain. Baseline scores 5 to 6. And then you can see one thing that I really liked about this systematic review is that they looked at the studies and they assessed the cannabis products that were utilized. So whether it was a high THC cannabis product all the way down to cannabis products that had no THC. So either, so basically all CBD use. So you can see that a majority of the studies, 10 were using that high THC component and very, very small amounts of CBD. And then 7 studies using a 1-to-1 ratio. So nabiximols, that is a cannabis product that is utilized in Canada as well as in Europe, fairly commonly for neuropathic pain. And so that was where this evidence came from, were those studies. So in looking at a breakdown of the studies, again, you can see that neuropathic pain was the most common type of pain. And for the studies that had the high ratio of THC, there was a moderate improvement in pain. So it reduced the pain score, by a little bit more than 1. Which could be, maybe that's clinically significant for some patients. And then as you would expect with patients who are on, a product that contains a higher amount of THC, there was side effects of sedation and dizziness when compared to placebo. In terms of the 1-to-1 cannabis product, so this was about, the ratio is, roughly like 5 milligrams of THC to 5 milligrams of CBD. Again, neuropathic pain, and there were small improvements in pain. So I don't know that, this reduction in pain was what I would classify as clinically significant for those patients. And again, even though it is that 1-to-1 ratio of THC and CBD, there were still incidences of dizziness, sedation, and nausea. Unfortunately, so the area that I'm most interested in and where I would really like to see more robust studies is with use of CBD or cannabidiol for different disease states, just since it tends to be a better tolerated product and I don't have to worry about some of those CNS related side effects. But for this systematic review, the evidence was insufficient. So they really weren't able to evaluate the impact on pain, mostly because the studies didn't have a process to evaluate it objectively. So this is the information that I just reviewed, but in a form that's, a lot easier to visualize. So you can really see this is that high THC ratio, and both synthetic THC products. So synthetic products would be dronabinol and nabilone. You can see that it favors the cannabis product. And then for extracted THC, which is going to be much more potent, again, it does favor the THC product compared to placebo. This is the comparable where there were a few studies where you can see that it does favor in terms of decreasing pain for this 1-to-1 ratio, but then just a few more studies where it is kind of even, where there's really no difference between the cannabis product and placebo. So then other areas, this was another review that specifically looked at non-pain related disease states and cannabis use in older adults. So end-stage cancer, Alzheimer's disease or dementia, and then Parkinson's disease. And so for these different conditions, you can see that there are potential benefits that are listed, and in parentheses, the ones that were related to a specific cannabis product, I have that listed there. The one that I want to focus on, because this is another area where I feel like we get a lot of questions from our patients, is with Alzheimer's disease and dementia, specifically related to those behaviors like agitation. So in the studies that they looked at, they did find benefits with agitation and aggression, cognitive functioning, specifically with nabilone, which is a synthetic THC product, neuropsychiatric symptoms, nutrition, appetite, as well as sleep. And then adverse events or potential harms that were listed were psychedelic effects, sedation, somnolence, and then some balance issues as well. So again, most of these products, or all of these products, are THC-based products, and so I'm not very surprised with the potential harms that are listed there. So before we go into a few more studies on Alzheimer's disease and the use of cannabis, these are, some of the mechanisms that have been proposed, why cannabinoids may have a place in helping with agitation and some of the behaviors related to Alzheimer's disease. So this is a systematic review of 12 studies where the MMSE ranged from, as you can see, severe to more mild. So, a very large range for that MMSE score and for patients with Alzheimer's disease. 4 of the 12 studies found significant improvement in the neuropsychiatric symptoms. So you can see the NPI, it was reduced by 10 to 11 points after 28 days, and that was specifically with dronabinol. And they also saw significant improvements in the Pittsburgh Agitation Scale. However, 8, so a larger majority of these studies really found no benefit. They didn't find improvements in the NPI or improvements with the Pittsburgh Agitation Scale. The doses that were utilized, so again, these were all THC based, anywhere from 0.75 milligrams twice daily to 1.5 milligrams 3 times a day. And then, as you would expect with a THC-based product, sedation and dizziness were the most commonly reported side effects. So this was a study that I was really excited about to present on, which is why I kind of gave the sneak peek of the systematic review. This has been going on for 8 years. So it started before COVID, and then obviously during COVID there was a struggle with enrolling participants. But this is called THC-AD, and this is pilot data that was presented at a meeting last fall. And I actually just checked the beginning of this week because they were thinking that they would potentially have final results sometime this spring, but they're not published yet. So this is still information from the fall, but this was a 3-week placebo-controlled, double-blind, randomized control trial for adjunctive treatment of agitation in patients with Alzheimer's disease. And so the intervention was adding dronabinol, which is a synthetic THC product, 5 milligrams twice daily, and they did administrations at 8 a.m. and at 2 p.m. And you can see with this pilot data where they provided the baseline data. This is of 58 participants, but by the end of this presentation, or whenever they released the pilot information, they had up to 75 participants enrolled. So mean age, this is a study where it does have older adults, so 78 years with an age range of 65 to 94. You can see the other information listed there for participants, and then some of the baseline clinical data that they looked at initially. So the results that were presented as of October of 2024 were with 75 participants. And you can see that the Pittsburgh Agitation Scale, there was a decrease, about 30% decrease. And then there were very few side effects for those patients who were on dronabinol. So 2 with delirium, 1 had a fall with injury, and then 1 with sedation. So there appear to be some side effects, but not as many, I guess, as I would imagine with using a synthetic THC product. The other notable thing with this study is they commented that by the end of 3 weeks, more than 50% of the participants were actually able to reduce or completely stop their antipsychotic. And so, when you think about some of the risk of antipsychotics, that, some can have metabolic side effects for patients. Some have, major interactions with other medications. They may cause issues with QTC prolongation. This could be an option for those patients. And dronabinol is an FDA approved therapy. It doesn't have FDA approval for Alzheimer's disease or agitation right now, but that could be coming soon. So for me, something that I was hoping to find, or I just wanted to do, a comparison of is how does dronabinol really compare with some of our other agents that we may use for agitation? So brexpiprazole, that is a newer drug that can be used for agitation, and you can see the different changes when compared to placebo, and then the NPI mean difference. And so negative 4.6 when you look at dronabinol, and with this study, the NPI reduction was about 10 to 11. And unfortunately, I couldn't find anything like that related to quetiapine, but so, I think that could be something for future studies if there is a thought that we're going to be using dronabinol for agitation. So, hard to know right now if dronabinol is, safer because in this study they did use it as adjunct therapy. And then really quickly with sleep, so this is evaluating CBD for sleep. I will say there were only a few patients who were older adults. The CBD dose really ranged to some of those higher doses, and they evaluated patients who had anxiety as well as patients who were poor sleepers. You can see the baseline information, and if you really focus on those patients who were just using it for sleep, you do see, a reduction in that sleep quality index. And one thing that I do want to note is that it does appear when you utilize CBD for sleep that those effects wear off after about a month. And so one of the findings was that they really did find that CBD effects on sleep decrease over time, and often patients have to continue to increase that dose of CBD. Just for sake of time, this was just a study or a survey of patients who were using medical cannabis, and the overall result was that it was associated with less waking up at night, but no difference between like falling asleep or waking up early. And then I have this picture here because this is about the amount of cannabis that the patients were utilizing in a month in order to have the impact on sleep. So a pretty large amount of cannabis was utilized to assist with sleep. So in summary, mixed evidence for dementia-related agitation, but maybe a use for dronabinol to be determined whenever we see those final results. I think right now the biggest evidence is related to neuropathic pain, and then insomnia. We just need insomnia to actually be studied as a primary outcome versus looking at secondary measures. And so with that, I know we're right at time, but I will take any questions.
Thank you, Dr. Fixen. That was an excellent presentation. I'm excited to see more in the future, I hope, more studies. Do we have any questions real quick? We're kind of past time. Well, not seeing any questions, I think we will conclude this meeting and see you guys all at the annual conference on Friday, April 25th.
And would you guys like, I'm happy to send, I don't know if you share like copies of presentations, but I'm happy to send or share a copy, or I think I actually, like, you're more than welcome to share my Grand Rounds presentation too, since I know that you have that and it's a little bit more, it has a little bit more information in it.
Okay, great. Thank you very much.